Now we turn our attention to obesity. Now, the time that I dedicate to obesity does not reflect its severity. It is the real issue here is that obesity is very prevalent in our culture. It's on the increase, it's on the rise across populations. Probably one of the most concerning demographics is that obesity and type 2 diabetes are on the rise in the young population. And when I say young population, I mean juvenile, which is generally referred to as people kind of under the age of 21. No offense if anyone's below the age of 21, but just in medical and demographic terms. So basically, young onset type 2 diabetes is a growing demographic, and that's directly related, and or it is most likely. I haven't looked at the specific data on that, but it's most likely directly related to the obesity situation in that younger population. So those two things are concerning for where things are going in that population. So I want to briefly touch on this topic. We will touch this in various components when we talk about type 2 diabetes. We'll talk about it as it relates to other medical conditions within the endocrine world. And you will also see this topic come up in subsequent classes as it has an impact on other conditions such as renal function and and cardiac function. List goes on and on. I don't know, like for board exam, that kind of logic, how prevalent specific questions about obesity will be. There are a couple of things I'm going to emphasize, and those will be kind of the focus things I need you to know related to obesity. And we'll just get into that, and I'll call attention to it when we get there. So, the main thing what I want to start with is how medically we diagnose obesity. And you can see here that there is a classification of weight from underweight, healthy weight, overweight, to obesity, and then extreme obesity. And you can see that there's, in the medical world, there's obesity class 1, 2, and 3. And you can also see there's a disease risk associated with 1 being overweight, with 2 being your disease risk is much higher with obesity. And you can see then it gets to very high and extremely high when you move to stage 2 obesity, and then stage 3 obesity or extreme obesity. You can see there how that progresses. This is generally determined based on body mass index. So granted, body mass index is not necessarily the best indicator of body composition, but that is the way the medical field right now, it's the best guidepost we have for determining obesity classification. And obviously, some patients and individuals are going to be thrown out of this. If, for example, bodybuilders, their body mass index is going to be high, and it's not going to be because they are obese. It's because they have a very high muscle density. So that said, I want you to know that this breakover where basically if you are at a BMI of between 25 and 30, basically 25 to 29.9, then that is considered overweight. And then obesity is 30 to 34.9, and then 35 to 39.9 is class 2 obesity, and then extreme obesity is greater than 40. So those will be key points to remember going forward in class. Now, what we know about obesity in general is that there's nothing that works really well across populations. There are surgical interventions, there are medication interventions, and then of course there's diet, behavior, physical therapy. There's been a lot of things that have been tried, from medications that block the absorption of carbohydrates and fats, medications that or foods that do not allow the fat in them to be absorbed. There's just been a whole litany of different interventions attempting to address the issue of obesity. And what we see in the medical world, in the healthcare world, not in the fitness world or infomercials or any of those things that are proposed to work, but in the medical field, what we are aware that is most effective is a multifactorial approach that involves diet, physical activity, and behavior therapy. And so what I want to be clear about here is what we mean by these things, not just what is called to mind. So diet therapy, while it does indicate putting someone on a diet, it's not necessarily about calorie restriction or food restriction. It is about having a healthy diet that's composed of good calories and from good food sources. In other words, where you may have a hamburger, however, that could be on the diet, but permitted on the diet, but it's not one we get at McDonald's or Wendy's or someplace like that. It's something you make at home, maybe with a whole wheat bread and perhaps not loaded with cheese and dressings and all of those things. And then as a side order, perhaps like a baked potato instead of deep fried French fries, things like that. So there are modifications to the diet that mean the patient or individual is going to be consuming healthier calories. So more salads, plant-based foods, etc. There are a variety of modes to modify the diet so that the calories that are consumed are more efficiently used and are better for that individual to, one, stimulate their metabolism, and then also provide calories that are efficient and not calories that provide a lot of saturated fats that are going to be stored as triglycerides, low density lipoproteins, etc. Now, physical activity is also part of it. And when I mention this as therapy, I'm not talking about something like CrossFit. Now, obviously, if you've got someone who is overweight and they've done intense exercise and they want to do CrossFit and they're conditioned for it, fine. What we're talking about here is physical activity that is intentional and purposeful for the purpose of increasing metabolic rate. And that could be something as simple as going for a walk, 1 mile walk, progressing from a mile to 2 miles, not necessarily trying to get to a half marathon walk, but a consistent physical activity that is above the baseline of the individual. So what is not necessarily clearly understood by most people is that something very simple works very well. And this then gets back to behavioral therapy, which is not about therapy like sitting down with a therapist. It's about modifying, that may be a part of it, but it's about modifying behaviors to help facilitate a good dietary and physical activity implementation. So, for example, you may have an individual who's overweight and there's an important medical reason for them to lose weight. And the dietary intervention here is going to be to try to get them to purchase good foods. Well, there may be a behavioral challenge in that they're used to going to this particular grocery store. And when they go into this grocery store, they walk by, the entrance goes by a deli counter where there's fresh, or the bakery department where there's fresh baked goods there. And so the smells then trigger things, the appetite, or the triggers the brain to say, boy, that smells good. Now I'm thinking about sweets, or I'm thinking about some cake, or I'm thinking about, or perhaps, it goes by a fast food counter at that particular store. Now I'm thinking about French fries or unhealthy foods. So behavior change may mean, one, they go to a different grocery store or choose a different entrance. So these are simple behavioral changes, and then they're choosing intentionally from a list, perhaps they've generated ahead of time, that's like, this is what I'm going to eat this week. So there's some strategic interventions here to bring about behavioral change. And you have a list, and you go in, you buy from the list. You don't buy anything that deviates from that list. And that list then is your plan for your meals for the week. So that's an example of how behavioral therapy might tie in to the groundwork of diet therapy. So then you add the other components here. You're trying to integrate these components. It's the most effective thing is the most integrative approach. And then what we would hope would accomplish is somebody would institute physical activity like this in the evenings, or perhaps in the morning after breakfast. Obviously, temperature is going to matter, and location. There are many environmental factors to this. You may have heard of the social determinants of health, that things in your community that either facilitate or block things like physical activities. Like our neighborhood does not have sidewalks. So that might be a challenge for someone who's trying, and it's very hilly. So someone who's trying to initiate physical activity in our neighborhood would find that challenging. Whereas someone whose home backs up to Lake Atalanta, it would be easy for them to step out of their house onto a sidewalk, a protected, well-lit area, and where that's populated, where it would be easy to take a low-intensity walk and begin physical activity. And the hope would be that someone would do something like they've eaten a healthy diet, or they're eating a healthy diet, they've made that change, and then they add the physical activity of going for a walk after eating. And it's been established, and you can look this up, that one of the best fat burning exercises is low intensity exercise right after eating. So eat a meal and go for a walk. It doesn't have to be at a rapid pace. Obviously, we don't want a walk that is very, very slow, like 2 hours to walk a mile or something like that. We want a decent pace that is physical activity and not just a meander, but it doesn't have to be a race walk. Someone doesn't have to be walking for time. That low intensity physical exercise enables fat burning right after eating. So here's another habit that is a behavioral modification that's got to be instituted. So you can see how these things tie together to accomplish ultimately the goals of therapy. And the intensity, obviously, and the length of this thing is going to obviously vary according to the severity of the obesity class. So the picture below this shows you a kind of related to obesity rating by BMI, the levels of interventions that would be beneficial. So you can see here, if they are in the 25 to 26.9 range, the intervention, the treatment there would be diet, exercise, and behavioral therapy. So there is, if they've got comorbidities, those are the interventions we would try. And what I want you to notice is that as we increase in obesity class, then that's where the different interventions get added. So as you move from overweight to obesity class 1, or obesity, I should say, because the last 3 are obesity class 1, 2, and 3. You move to that 27 to 29.9, then we add pharmacotherapy. So this is where people in this BMI range may add things like Ozempic, which is an example of one of the current weight loss medications that's out there. And then when people move that is the recommended therapy for the range of 27 27 to 29.9, and then 30 to 34.9. So those are the recommendations in that range. The pharmacotherapy, that we may add an additional therapy, additional medication, we may adjust the dose. So there are a variety of interventions that could change when that BMI is higher. It is only until we get into class 2 or 3 severe obesity that we end up with surgical interventions, where surgical interventions in the presence of comorbidities gets added. So again, that reflects that there's stuff going on with this patient that's a threat to their life, and then we have issues to weigh whether we have surgery or not. And because obviously with surgery, there's a risk. There's a risk of people dying. There's a risk of infection, a variety of risks associated with cutting somebody open just because of their weight. So these are the current recommended guidelines out in the medical world. Now, what I want to illustrate here, so you can see the complexity in managing. Before I speak to this slide, in this slide you can see the complexity with managing this alone. There have been a lot of medications that have been tried over time. That medication alone does not work. There have been surgeries that have been applied, and surgeries alone do not fix it. People gain their weight back. There's not a magic bullet here, is what I'm trying to convey. And the effective treatments are the ones where people employ multiple components to try to change their life. A lot of the medication treatments that have been out there, diet medications and that sort of thing, they either fall in a couple of classes or a combination thereof, and that is a stimulant or an appetite suppressant, and sometimes a combination of both. And when you get that in a population that is relatively on the continuum unhealthy, you run increased risks of tachycardias, arrhythmias, and life-threatening conditions. So there's definitely risks associated with that, and those changes typically only persist while the patient's on the medication. So that's why behavioral changes have to be in place to modify the way that people have consumed to get there in order to sustain it once a goal weight is achieved and the medication is stopped. Because if the behaviors haven't changed, there's not a physical activity adjustment or diet adjustment, then it's just going to return. One of the things we're seeing with the use of Ozempic and like medications in this weight loss modification is we're noticing there's some anecdotal data that's starting to emerge that patients who are using Ozempic also do things like, in addition, they're losing weight, but they're noticing their cravings for foods are diminishing. Some of them are quitting smoking because their craving for smoking or alcohol is also subsiding, so that's diminishing. They're also doing things like buying less on Amazon or other type of consumer type behaviors. So they're consuming less, not just when it comes to food. There's something that's probably going to show up to be associated with dopamine and the reward center of the brain, that Ozempic is having an effect there as well. And that kind of points to a more global effect on this mode of consumption. Here's the challenge: even with medications like Ozempic, and those changes occur while they're on the medication, and unless intentional changes are made while they're on the medication to create new habits, then once they've finished their course, then the weight's going to return because the behaviors haven't changed, the habits haven't changed. So it's easy to say that and talk about it. There are a lot of challenges associated with appetite control. And I have this slide for you not to memorize, because there's much on here, a lot of abbreviations and acronyms that you really don't need to commit to memory. What I want to call out are some things that make sense to you and also some things you may have heard of out there in the world related to appetite, kind of show you how they all fit in the picture. So what you have in the center here are central controllers of appetite. So what is meant by this, by central controllers, this is in the appetite region of the brain where we have the sensation that we need to eat, and where the sense of hunger, we need to eat more, we need to eat less, those central mediators that affect whether, when, and if we eat. And serotonin, you notice here, decreases that appetite. So it mitigates some of that sense of need to eat. And then you have some other things such as NPY, MCH, orexin, and endocannabinoids that stimulate or increase appetite. Now, I know you haven't heard of endocannabinoids before. Cannabinoids are related to something you had heard of, which is cannabis. This is exactly a similar type compound. It's called an anandamide that exists in the body. And cannabis draws its name from the chemical name tetrahydrocannabinol. And the cannabinol-like drugs, basically, one of the side effects of those compounds is that they stimulate appetite. You may have heard of people who are smoking weed, marijuana, having the munchies. It's a common association with marijuana consumption. That's a result of the cannabinoids. And there is a drug out there called cannabinol that is prescribed for patients who have diminished appetites. It also gets prescribed for people with cancer to stimulate their appetite and also suppress their nausea, because it does suppress nausea as well. So you can see how that drug works in the central portion. Well, it works in the central portion of the brain to increase or stimulate appetite and also suppress nausea. And serotonin having an opposite effect. I certainly don't expect you to memorize those acronyms. What I want you to see is there are multiple hormonal compounds that impact our desire to eat. This is without any associated cultural, family, trauma, etc., associated with eating, or psychological issues associated with eating. So this is just what is going on in the brain to begin with. It's complex. Then in natural response, we've already introduced, and we'll discuss further, the impact of insulin and cortisol and the role it plays in, as well as glycogen and glucagon, the role it plays when we have a sense of hunger or satiation to either tell our brains to quit eating, or tell us we need to eat. So those hormonal components from organs outside the brain have an effect on the brain and our response to eat. And then various metabolites that we secrete from eating, that are a result of eating, such as glucose and ketones, those also have an impact on generating our desire to eat. Now, there are also two other components that I want to call attention to, because they create the complexity, they illustrate the complexity, and then add layers of complexity mentally, emotionally, psychologically onto our eating behaviors. And those are psychological factors and cultural factors. So what I like to call out here is different cultures have different habits about the way meals are done. And a common cultural component is, and many of you may have heard this before, clean your plate. That's a cultural norm that doesn't exist everywhere in the world, but it's common, particularly in the South. If you've scooped it up onto your plate, then you need to respect what you've done, and respect be respectful, and eat everything that's on your plate. And while there is some, I guess, some, what am I trying to say here? Some conventional wisdom about teaching certain behaviors, about how much food you take and then how to eat it. There's also some challenges, some detriments to that, because sometimes we are served food and we're not putting food on our own plate, and someone may serve us more than our capacity to consume. And that cultural factor of clearing your plate could be detrimental in the whole issue of how we eat food and our relationship to food. There are other cultural factors. For example, there are families or cultures that have a big production, or it's a big family event to have a meal, even meals, day-to-day meals. Everybody's home for them. They're done in the kitchen. There's a lot of preparation. Everybody's part of it. Perhaps there's tasting and things that go along with it. It's a big social event. It's an important thing. And and some cultures have more pastas associated with their diets. And what that can then create in us is an appetite for pasta or carbohydrates, which it tells us in our brain we're satisfied when we've had this, or even meat is another example. A meal is not a meal unless there's a piece of meat on the plate. Again, cultural factors that influence the things we're hungry for and what constitutes a complete meal, and what tells us in our brain that we're going to be full and finished when we finish. Then there's psychological factors, and psychological factors, as you can see, can easily get enmeshed in cultural factors. But psychological factors have to do with things like comfort foods and foods that are connected with situations that make us feel safe or protected, and also make us feel like we're perhaps in danger or in harm's way. And when people have had trauma associated with in the parameters around time, in the periods before or after meals can be associated with those traumas. Also, people can associate a particular type of food with bad comments or abusive language that has come their way. An example being someone that's, not everybody can't eat ice cream because, you'll get fat or something of that nature. So people can associate those foods with negative self-images, and they can reinforce negative self-images. And then there's another piece of that comes into play, and that is that people will abstain religiously from foods like that, and then that can then result in a desire to crave it because it's forbidden fruit, if you will, and that then can induce a craving or binging on that particular thing in the event of another unassociated trauma. So as you can, and again, I'm speaking in general terms. I'm trying not to get too concrete because I don't want us to dissect it all. What I want you to appreciate is when we sit down with people who have health concerns as a result of their weight, and we begin to say something like, we need to change the way you eat, I want you to have an appreciation for how challenging that is, depending on the factors that are contributing to this, as well as the years that these habits have been in place, and some of the things that we may not, as nurses, be skilled enough to unpack in these people to help them to be able to move in that direction. So it's a very challenging dynamic, appetite control and making changes. Now, this slide is important for you to be aware of and cognizant of. What this slide does is shows you the few conditions. In this case, there are 6 listed here. 6 syndromes that are genetically associated with obesity. And what I mean by that is part of the manifestation of these illnesses is an obese body composition related to these genetic disorders. That's different from someone who has a propensity to be overweight or obese because of habits that are formed in the family that are perpetuated from generation to generation, because that's the way meals are done in a particular family, and that's the way fitness is either not or is not done in families. There's a difference between someone who is genetically predisposed to obesity in this way related to obesity syndromes and someone who has a propensity toward obesity because of familial factors, cultural factors, or other psychological challenges. So notice here that Prater-Willi, Lawrence Moon Beidel, Alstroms, Cohen's, and Carpenter's all have obesity as a part of their clinical manifestation. The obesity is a little bit different in the first 2. It's more of a generalized obesity that can be moderate to severe, usually evolves over 1 to 2 years, and these patients are usually young when they start manifesting it. And similarly with the other 3, usually in the younger years, notice onset 2 to 5 years, around age 5, so in the early years of life. And the obesity is truncal. In other words, it's usually between the chin and the waistline. It's usually in the trunk, the center portion of the body. So I don't care that you memorize all of the details. I just want you to be familiar. If you were to see these conditions, you would know that there is a genetic component to the obesity in these particular individuals. Now, having said that, that doesn't mean that the predisposition toward being overweight is any less difficult to overcome. So I just want to emphasize that too, that those predispositions. So when I say that, what I'm referring to when I say predispositions is there are people who have a higher appetite, higher appetite for sweet things, carbohydrates, for example, things that we know contribute when consumed in excess. People who have a propensity toward alcohol. Alcohol has a lot of carbohydrates in it. And people who are just not as drawn to physical activity are more less interested in that sort of thing, and enjoy a more sedentary lifestyle. Those things are going to be predisposing factors in addition to anything familially, culturally, or psychologically that contributes. What I want to do with this slide is show you some of the comorbidities associated with obesity. And these are not necessarily, I don't want you to think of them as chicken or egg. It's not like one comes first and then the other. They can contribute to each other. So there are a multiplicity of conditions here that are connected with and have a direct link to obesity. Thyroid cancer, for example, effect on the thyroid can change metabolism and can contribute to obesity. Respiratory conditions such as asthma, emphysema, bronchitis, obstructive sleep apnea, and respiratory infections are commonly associated with obesity, and things like obesity make you more likely to have sleep apnea or to develop COPD. There is a correlation there. If you have type 2 diabetes, you have a higher risk of developing obesity. And if you are overweight, you definitely have a higher risk of developing type 2 diabetes, as well as pancreatic cancer. NASH, non-alcoholic fatty liver syndrome of hepatitis, or non-alcoholic fatty liver disease. Those are also associated with being overweight, as well as liver cancer. And then GI things like cholelithiasis or gallstones, gallbladder issues, gallbladder cancer. All of those conditions definitely can be a contributor to or associated with, not a contributor to, obesity can be a contributor or an increasing risk factor for those conditions, as well as things like osteoarthritis. The less active you are, the more pressure and weight you're putting on your bones, then that can definitely increase your risk of developing arthritic conditions in your joints, particularly of the lower extremities. And then also some things we're not going to discuss in this particular class, you'll probably cover in the psych component, things like Alzheimer's disease, anxiety, depression, that sort of thing. Those are all risk factors. Well, and a stroke, obesity is a risk factor that complicates those or puts one at risk for those conditions. So the takeaways here for obesity are: one, it's a complex issue, and it needs to be addressed in a multifactorial way. That also is going to skip back here to this. Also, that there's not one straightforward solution for the management of obesity. It's a complex issue. It requires sensitive and intentional effort to address. And the other thing that is important for nursing students and nurses to take away from this is that it is not our job to value the individual based on their body composition. That you have probably already encountered snide comments at nurses' stations or allusions to someone's weight in the nurses' station, or attitudes towards people who are overweight or obese, or even morbidly obese. The biggest takeaway for us in that regard is we have to check our biases, our opinions at the door. And when we go in the room, we're treating this person with the respect and dignity that they deserve. We take our own predisposed ideas and conceptions about obesity and what that person is like that's caused them to become obese, that whether they have lack of self-control or whatever, we check that at the door, and we bring a open mind and respect and compassion to the bedside so that we treat people appropriately regardless of their body composition. So with that, that's what we'll touch this a little more in class, and there you go.